I have the pleasure of introducing Professor Edward Nardell. He is a physician at the Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. He will present on COVID-19 spread, a role for air disinfection.
So thank you for the invitation to speak this evening. As mentioned, my area of interest is airborne transmission of infection. Particularly, I've studied mostly tuberculosis, but it turns out that area of tuberculosis transmission is very well suited to dealing with anything that's airborne. And as it turns out, SARS-CoV-2 seems to be predominantly airborne, even though initially we were told by WHO and by CDC that this was an infection that was spread largely by large droplets directly and on surfaces. And while those two modes of transmission can't be dismissed, we found ourselves for many months and still to a large extent disinfecting lots and lots of surfaces without really impacting airborne transmission at all. So let me begin with a little bit of a discussion on this. So is SARS-CoV-2 airborne? The evidence is almost always circumstantial. In the case of tuberculosis, it's very clear, but here's how the reasoning goes. If large respiratory droplets contain virus, and they do, small ones must also. And in fact, small ones don't necessarily contain less virus because as particles evaporate into small particles, the viruses don't go away. So the particle gets smaller, but viruses remain. And viruses have been detected in air sampling and, of course, on surfaces as well that result from particles that land on surfaces. Other similar coronaviruses, the original SARS and MERS, another coronavirus, have had airborne components very clearly. Examples of spread likely to be airborne, the Washington State Choir, we all heard about that early in the epidemic, where something like 50 out of 60 people attending a choral rehearsal over a 2.5-hour period became infected. 2 people actually died. And what's remarkable at that is that there were extraordinary precautions taken to prevent contact spread because people thought this was a contact spread infection. So nobody was touching, people were socially distanced. Obviously they weren't wearing masks for singing, and we know that singing is a major way of generating aerosol. There were, for SARS, an apartment building in Hong Kong where spread occurred between floors among people who had no other contact, very convincing for airborne spread. And there was another Hong Kong apartment building in the lay press. I haven't seen a scientific article about it suggesting the same kind of thing for SARS-CoV-2. I don't have a paper on that. The Wuhan restaurant was a restaurant where transmission occurred from table to table. Now that could be large respiratory droplets, and although we like to make the distinction between large and small respiratory droplets, in fact, obviously it's a continuum, and some of these particles that would settle within a short distance of the person speaking or singing will go further if there is a fan, or in this case there was a air conditioner on the wall pushing the air in one direction and resulting in table-to-table spread. And then a very important factor is the surprising impact of face coverings, masks, really thought to be somewhere above 70% effective if both people who are infectious and people who are at risk of being infection are both wearing face coverings. And that could be preventing you from touching your face, it could be large droplets, but most people think it is actually airborne infection, even though surgical masks are not designed to protect from airborne infection per se. A very important thing, and I'll show you another slide on this, is the impact of indoor environments. I think we've all come to realize that there's been a big change in transmission rates once the weather gets colder, people start going inside, and that indoors, of course, there's more close proximity. Droplets could be spread that way as well, and contact with surfaces might be more often, but it's a major factor in terms of rebreathing the same air, and I'll emphasize that again. So this I actually found on the web, and it is a graph showing the hottest states suffering the worst outbreaks between May and June of this year. So if you look at the outliers, on the bottom of the graph are the cooling degree days in the previous year, assuming that year after year the climate doesn't change that much. So you'll see that Florida and Arizona and Louisiana and Texas are all on the farthest end of needing the most air conditioning, meaning people are indoors or have the air conditioning on. And they are also high above that horizontal bar, meaning they've had somewhere between 50 and 150% increase in cases when the climate became such that they needed to use air conditioning. And at that time, states like where I am in Massachusetts and in the cooler states were having much less problem. We were outside more, et cetera. Now that we're inside with cold weather, and in fact a big snowstorm happening starting tonight, we're seeing obviously a lot of transmission again as well. There's a modeling paper that Rachel Jones did in 2020 looking at transmission. Actually, it was in a hospital setting, and looking at close field, far field, hand, contact, droplets. And the conclusion was that the droplet and inhalation transmission predominated over the contact route, with droplets being about 35%, inhalation about 57%, and surfaces only about 8.2% of the cases. Probably. We don't have absolute evidence in these cases, but so this is a very important concept to get, I think. When we think about public buildings, schools, hospitals, wherever, when airborne has been mentioned as the cause of transmission, our engineering friends often jump on filtration, and they want to put filters in the ventilation system to stop recirculation. It's very clear at this point that there is no evidence after almost a year of COVID experience of transmission through the ventilation system. So in my view, putting filters in the ventilation system, although there are many reasons to put filters in a ventilation system, dust and pollen and other things, is probably not contributing greatly to safety. It does make all of the recirculated air essentially fresh air because it's been disinfected by a filter, but if that air that comes back doesn't have virus anyway, or enough virus to cause infection, which is what the observation suggests, then it may not be doing any good. On the other hand, in the little box I have in the room, and you have somebody who's asymptomatic, who is generating millions or billions of viral air droplets over the couple of days that he's infectious, and someone else in that room. It's very little comfort to know that when the air leaves this room and goes into the ventilation system, it's going to be disinfected. If you're going to do something, you have to do it in the room where transmission is occurring. And there are only a few choices: high volume ventilation, which most buildings are not built for, room air cleaners, which can be purchased and installed, or I'll be telling you about upper room germicidal air disinfection. So what I've shown here is the person in the room, someone else in another room serviced by the same ventilation system. If you put a filter in the way on the return duct, then this air that leaves that room will come back to the other rooms disinfected. The issue is, however, there isn't any evidence of transmission that way. And the reason why, I think, is that when this person is generating aerosol, it first gets diluted in the room that you're in, reducing the chance of an infectious dose. And then it gets further diluted in the ventilation system with air coming from other rooms. So that time it gets around to another room or back to the same room, it is, in fact, if the virus is still stable and active at that time, it's been substantially diluted. And the infectious dose is thought to be somewhere between 300 and 1,000 viruses. So it's not like one or two viruses are going to cause infection in most people. So this is a huge problem globally, and more and more people are purchasing around the world split system air conditioners. They're relatively new in the United States. We've mostly done window air conditioners and central air conditioners, but these are very sleek systems that are on the wall with all of the noise and the apparatus outside and no air going between outside and inside, just coolant. So this takes hot air and makes it cool air. To run it efficiently, of course, you have to have the windows closed. And split system air conditioners, which is what they're called, sales in places like India are skyrocketing. Well, they're skyrocketing in the United States as well in hot climates as they get hotter. And you really find yourself cool but comfortable, which is the name of an editorial that I wrote on this subject, published in a journal called Indoor Air. In other words, you close the windows, turn on an air conditioner, and everything feels better, but in fact, you're rebreathing the air that somebody else has exhaled. So if you're going to do that, you need to somehow disinfect the air in the room where you have this closed system going on. Here's what happens in a room when you close the windows and turn on the air conditioner. This is 5 people in an office. This is the editorial, by the way, in Indoor Air this past year, cool but dangerous. And what happens is that carbon dioxide levels in that room with 5 people, it's an office, and with the window open. And then we ask people to leave, we close the window, and CO2 levels go down a little bit. Then they come in, we close the window. This was open window. We close the window and turn on the air conditioner, and the CO2 levels in an hour, just 1 hour, more than double, indicating that the risk of airborne infection just went up by 2. So what can we do about that? Well, as I mentioned, there are 4 options. There's natural ventilation, in other words, windows open. You can't do that and have an air conditioner. It doesn't work very efficiently. You have mechanical ventilation, but most mechanical ventilation systems in schools and homes are very limited in terms of how much fresh air they can provide, and many provide mostly recirculated air, but also only a couple of air changes per hour. Room air cleaners, like the one depicted here, can be purchased. And the problem with those, let me just say in the upfront, is that you're trying to get all of the volume of the air in the room through this box. And you have a blower in there trying to accomplish that. And that's a big task for a fan to do. And to produce the kinds of air changes that CDC recommends for airborne infection control, 6 to 12 air changes, is quite difficult. It can be done. You do get some recapture of air that was just processed back into the system. So even though it's working hard, it may be reprocessing the same air over and over. But they can produce air disinfection. We just bought 4 of these for the gym in my building that we'd like to reopen because the ceilings are too low for the next solution I'm going to talk about, which is upper room germicidal UV. So these can work. But in our experience globally, they often don't work as well as one would hope because they're simply not sized to produce enough air changes, because very large ones are noisy and cause drafts and are expensive. So oftentimes these small ones you buy on Amazon or on Sharper Image don't do very much. This is an upper room germicidal UV fixture. You see upper room germicidal UV air disinfection. GUV, germicidal ultraviolet, and it's putting out germicidal UV through these louvers. And the reason the louvers are there is to keep this UV above people's heads because it will cause eye or skin irritation. It's not the same as the ultraviolet light that's in sunlight. It doesn't cause skin cancer or cataracts, but it can cause eye and skin irritation. So we keep it above people's heads. These are, again, pretty much what I talked about. Mechanical ventilation, often poorly maintained, very difficult to get the 6 to 12 air changes that CDC recommends. Hospitals can do it in isolation rooms. Room air cleaners, flow limited, oftentimes 1 or 2 air changes go through those devices. Germicidal UV, it can be in ducts, but I've already told you that disinfecting air in ducts doesn't do anything or very little for transmission occurring in the room. But in the room, it can be extremely effective and efficient in disinfecting the air. In fact, I don't know of a better way to disinfect air in a room than the upper room germicidal fixtures. It's not new technology. It's a 1946 monograph before I was born on using germicidal UV to disinfect the air. And in fact, in 1942, these fixtures were installed in schools in Swarthmore and Germantown, Pennsylvania, outside of Philadelphia, when a measles epidemic went through. And measles is the most infectious airborne infection there is. And you see that the primary classes, the younger kids, had the UV in these two different schools, and the older classes did not. And they favored the experiment to fail in the sense that there are more cases in younger kids who haven't been exposed before than in older kids. But you see what happens in those rooms that had the upper room germicidal UV. In fact, there were many fewer cases than in the upper classes where there was no UV in the room. It's above people's heads, disinfecting the air. This is the idea. This is a picture of a hospital room. It's supposed to be a fixture on the wall generating this zone of upper room, which you really can't see. It's invisible. But air makes its way up to the upper room because it's warm, from warm bodies or with mixing fans. And that air gets disinfected in the upper room and comes back as low-velocity ceiling fans are extremely good at assuring good air mixing. A colleague of mine from the CDC compared UV, ventilation, and 3 different air cleaners in an isolation room in Vladimir, Russia, and aerosolized some test organisms. And by far the least cost per equivalent air change was upper room germicidal UV. It was 9.4 times more efficient, and these are very simple fixtures on the upper wall, than any of the other systems that were employed. I was teaching at a conference in Pretoria, South Africa, and there was a salesperson for one of these devices there, an air cleaner, a room air cleaner, I'm sorry. And we looked for the specs, and we found out that it produced 60 cubic feet per minute. That's the clean air delivery rate of air coming out of this device that has been filtered. And in the room, in a hypothetical room that's 4 meters by 4 meters by 3 meters high, this would produce 2.1 air changes per minute, assuming not a lot of recapture, etc. If I put upper room germicidal UV in that same room, I could get the equivalent of 20 air changes at a fraction of the cost. We like to compare the efficacy of room air cleaners and UV to ventilation. That's why we're talking about air changes per minute, even though with UV we don't actually have physical air changes. We're removing virus or other airborne contaminants or making them inactive at a rate as if there were that much ventilation. So one air change removes 63% of air contaminants if it's well mixed. And when a UV lamp destroys 63% of the virus or bacteria in the air, we say it was the equivalent of one air change. So where do we use this? We think it can be used in healthcare facilities. My own hospital emergency room has UV in the waiting room and in some of the isolation rooms, and I had nothing to do with it. Emergency rooms, intensive care units, corridors, jails, shelters, nursing homes, and schools. Cambridge Friends School in the Boston area, private school, fully equipped with upper room germicidal UV. A few questions about safety from the parents that were easily addressed. This is very safe technology. And that's where an asymptomatic person may walk in the door. It's not going to be beneficial if airborne spread is not the principal pathway. For example, in nursing homes, I'm not so sure that disinfecting air is going to make a difference when people are at such close range, bathing residents, feeding residents, dealing with the toilet issues, and it may not make a difference. Likewise, if children were, for example, to ride home on a school bus, the fact that they don't get infected in school may be undone by being together on a school bus. So it's not a total solution, it's part of a solution. So going back again to this diagram, this is where we need to have very high levels of air disinfection in the room where transmission is occurring, which could be a classroom, could be a other congregate setting. And I am less enthusiastic about filtering the air in the return duct or putting UV in the return duct, which can be done as well. So we know this works. This is one study from colleagues at Hopkins. The study was done in Peru, showing that upper room UV reduced transmission of tuberculosis by 72%, 80% if corrected for some statistical issues. And we did a similar study in South Africa where patients were in room. The air was all ducted to these cages containing guinea pigs. Guinea pigs are extremely susceptible to TB, and just like hamsters are actually quite susceptible to COVID. We'd like to do this study for COVID as well. But for tuberculosis, which is harder to kill with ultraviolet than COVID virus, we also achieved about 80% protection. This is what a fixture looks like. We have a fan in the room, and air goes up to the upper part of the room, comes back, and is disinfected. We had the air on every other day. The lights were on, and on every other day, the air either went to this guinea pig colony or that guinea pig colony. At the end of several months, you'll see there were many fewer infections on the days when the UV was on. There were 57 infections in the control room, that is when the UV was not on, and only 15 when it was on. That's about an 80% efficacy, similar to the Peru study, equivalent to adding 24 air changes in terms of air disinfection. This is again what some UV fixtures look like. This is the paper where this study was published with an editorial by an engineer who's very interested in COVID engineering. Now, is this safe? Well, we do keep it above people's heads. There is some reflection into the lower room, but we know exactly how much UV one can be exposed to. And this kind of UV, UVC, is not what's in sunlight, which is what can cause skin cancer and cataracts. UVC barely penetrates the skin, and we can tolerate, without any irritation or risk, up to 6 millijoules per centimeter square over an 8-hour period, and we actually get much, much less of that. When this nurse, it appears, walks outside on a sunny day, she will get many-fold times that exposure to more penetrating UV walking to the parking lot. So this is trivial amounts of UV exposure, but it's enough to kill the organisms in the upper room. There's been a lot of work on the photocarcinogenesis risks of UVC, and the bottom line is that it doesn't get through the outer dead layer of skin, and there is really no significant short or long-term risk from UV exposure as long as we stay within the exposure guidelines, and even then you can get some skin irritation but not any real serious risk of cancer. One famous photobiologist said, yes, you can get skin cancer from germicidal UV, but it would take 300 years exposure. So in summary, SARS-2 seems to be spread predominantly indoors in large and small airborne droplets, and less so by contaminated surfaces, and particularly by the airborne route. It seems to be particularly spread in the room where an infectious source is present with little ventilation and dilution. Upper room UV is well-established, safe, and highly effective way, and very much underutilized. And it's also used for surfaces in hospitals. It's a different application. And there's a new form of UV that at the moment is too expensive to talk about, but it can be used in the room directly without being over your head, and very little penetrating and very, very effective. And there I'll stop.